Now it's my pleasure to introduce our keynote speaker, Dr. Charles Zeanah. Dr. Zeanah is a physician, professor, researcher, author, and tireless advocate for young children. His major academic interest has been in the area of infant mental health, especially understanding infant development in the context of infant-parent relationship. Dr. Zeanah has conducted research on the effects of abuse, neglect, serious deprivation, and exposure to violence on young children, and on the interventions designed to help them recover. He has studied approaches to understanding psychopathology in young children, in particular disorders of attachment, post-traumatic stress disorder, as well as interventions for young children who have experienced maltreatment. His current research is focused on how early experiences affect development, what is similar and different about psychopathology in the early years, and what are the neurobiological correlates of behavior disturbances in young children. Dr. Zeanah holds multiple academic and administrative appointments at Tulane University and also serves as executive director of the Institute of Infant and Early Childhood Mental Health. With us today to share his special and informed insights on how a child's early experiences shape the pathways to school readiness, health and mental health, please join me in extending a big Cleveland welcome to Dr. Charles Zeanah. Thank you.
Thank you so much. It's great to be with you. Wonderful to be in a community where there's so much passion and energy and commitment to early childhood mental health and young children. So I'm just going to jump right in. So there's this long-standing debate in psychology about whether the early years are especially important or just sort of important like any other 3 or 4 years in development. There are a lot of related questions to this, having to do with how easy or difficult it is to overcome early experiences of adversity, how much recovery can occur, and is it ever too late to intervene and make a difference? So the timing of interventions and, of course, the quality of interventions that we provide can tell us a lot that addresses scientific questions, addresses practical clinical issues, and of course informs our policy decisions. Particularly, how do we prioritize investment? Should we really be investing early on? And it turns out there are hundreds of studies showing that children who begin life in adversity have more problematic outcomes. But those studies don't really address the early experiences hypothesis because environmental conditions tend to be stable in large groups. So the only way to really look at do early experiences have unique importance is to look at children who begin life in serious adversity and then have a very dramatic change in their rearing conditions. So some of the work that has informed this is studies of children raised in institutions, and a lot of this work has been kids raised in Romanian institutions, which are large, impersonal institutions. There's a long story about it that I won't have time to go into, but basically these kids are raised in conditions that are far from the conditions that we would consider ideal, and not surprisingly, documented to be at increased risk for a whole variety of problems, from cognitive problems to social problems to psychological problems, etc. So one of the studies that I want to just mention briefly is a study that looked at kids adopted out of Romanian institutions shortly after the fall of Ceausescu. So this was in 1990, 1991, in the early days when these kids were discovered, adopted into families in the United Kingdom. So adoptive families obviously are a somewhat advantaged group. So you've got kids going from these deplorable institutional conditions into advantaged families in the UK. And what Michael Rudder and his team did is they looked at 4 what they called deprivation-specific patterns of behavior. quasi-autism, severe cognitive impairment, inattention overactivity, and disinhibited attachment. And what this slide shows is kids who were adopted prior to 6 months of age versus kids who were adopted after 6 months of age. So this is the amount of exposure that they had to this extreme adverse rearing conditions. And what you see is that an overwhelming number of the kids who had these deprivation-specific patterns through the age of 15 years, this is a longitudinal study, these kids followed from infancy through the age of 15 years, and almost all of the kids who had these persistent deprivation-specific patterns are kids who were adopted after 6 months of age. Only 3 children who were adopted before 6 months of age show these long-standing patterns of very problematic outcomes. Our group also did a randomized controlled trial comparing foster care to institutional rearing in Romania, and demonstrated that children placed in foster care at an average age of 22 months made significant gains across a whole variety of outcomes. This is IQ. So not only did we show that being placed in foster care enhanced IQ, we also showed that the sooner you got placed, the more likely your IQ was to make a bigger recovery. In fact, the kids placed after 24 months of age have IQs that are indistinguishable from the kids who were in the institutional rearing group. So all of the gains were kids who were placed prior to 24 months of age. At age 8, we administered EEGs, and this is a map of the amount of electrical activity in the brain. This happens to be in the alpha frequency, but it's true in other frequencies as well. And here you have kids placed in foster care after 24 months of age, in the care as usual group who had more prolonged institutional rearing. Here, blue and green mean less activity, and red and yellow mean more activity. So what you see is the kids placed in foster care prior to 24 months of age have electrical activity that's indistinguishable from a Romanian comparison group of typically developing kids in the community, whereas the kids placed after 24 months of age have electrical activity that's indistinguishable from the prolonged institutional rearing. Now, I do not want you to conclude that there's something magical about 24 months, because if you look across the range of outcomes and the range of studies that have addressed these issues, the most reasonable conclusion is the earlier kids get out of adverse environments and into good environments, the better, but not that there's a magical age. And our sample, and this is a sample-specific kind of thing, 24 months was important, but it wasn't the only point of timing. So because we're running late, I'm going to skip these videos and move on to this, because you can say, well, that's a bunch of Romanian kids raised in institutions, and what does that have to do with the problems that we encounter in Cleveland? So this is a study of Mary Dozier of kids who've been maltreated and placed in foster care. And it's a complicated slide, so don't worry about it. But basically, it's just to remind me to tell you that what this shows is that kids placed in foster care whose foster mothers are securely attached are far less likely to develop worrisome, disorganized attachment in the children than children who are placed with foster parents whose attachment is insecure. In other words, the quality of the caregiving environment that the kids are placed in makes a huge difference in their outcomes. Okay. So, 0 to 3 convened a task force, I'm sure you know, and they defined infant mental health as the young child's capacity to experience, regulate, and express emotions, form close and secure relationships, explore the environment, and learn, and that's a kind of accepted definition. But essentially what we're talking about is the quality of the child's primary caregiving relationships, and we have a ton of evidence now that this is the most important predictor of social and psychological outcomes. All caregiving relationships matter, which is why we have to worry about what's happening in the home, what's happening in the child care center, what's happening anywhere that the child is being cared for for a substantial amount of time. And we know exactly what the kind of care that we want caregivers to provide, because this has also been carefully studied and well documented. Sensitive and responsive care, knowing and valuing the child as an individual, and placing the needs of the child ahead of their own needs. This is what we're looking for, and this is what all of the interventions that you're involved in and that other people are involved in are trying to accomplish. Okay, so let's talk about the pathways that we alluded to earlier, pathways to school readiness. So there's a lot of emphasis these days on this construct of self-regulation, whether children's ability to control themselves, control their behavior, control their emotions, regulate all those things well, are predictive of outcomes. And it turns out, when you look at 5-year-old kids, you can predict, these are self-control quintiles. So this is high amounts of self-control, low amounts of self-control. And these 5 points here are the 5 quintiles. And this is looking at income at age 32 years. So you can predict from age 5 what the individual's income is going to be like at age 32 based on their self-control capacities at age 5. In addition, you can predict adult criminal convictions. The lower the self-control at age 5, the more likely the individual is to have adult criminal convictions, and diminishes over time with self-control. When we talk about school readiness, I think it's important that what the data suggests is that school readiness is not about cognitive development. It's really about social and emotional development. And in fact, security of attachment is a better predictor of being promoted from kindergarten than IQ is, because the child's behavior is what is so critical for school readiness. So to show this, I'm going to show you this little video. This is a 22-month-old Paul. Paul has been removed from his mother's care and placed in foster care. His mother's a young mother, 19 years old, has lots of serious problems herself, and we're assessing them in the context of our clinic in an effort to reunite Paul with his mom. This is a video of a little task that they're supposed to be working on together, and her instruction is to help him to the degree that she feels that he needs help to complete this task, which is a little hard for him to do by himself. And the task is, there's a little house. There are 3 holes in the top of a house, a square opening, a round opening, and a triangular opening. And there are 3 little doll figures, one of which has a square bottom, one of which has a triangular bottom, and so you basically match. And when you put the child through the correct opening, the 2 on the side slide out the side, and the 1 in the middle slides out the door. Now, I'm explaining all this because, as you'll see, there's not a lot of on-task behavior that occurs here. Okay, so this was the initial assessment. As you can see, this is a pattern of interaction characterized by teasing, by taunting. He's giving it just as good as he's getting it. He, as he takes the toy away from her, he's not going to let her have the toy. She's laughing at him. She's mortified, actually, that he's not cooperating, and she feels like she's making her look bad. And he's completely preoccupied with this intention of just messing things up for her, and so she's just going to mess things up for him. So it's like a couple of squabbling siblings, almost. And yet, it's more serious than that, because you can feel the anger just beneath the surface, and you can feel, this is his experience of what it's like to be in an intimate relationship, is to be frustrated and to be angry and to be thwarted and to have someone who you're constantly kind of plotting against, right? So we put this dyad into treatment. The treatment that we chose was something called child-parent psychotherapy. I'm going to show you 6 months later when the treatment wasn't over, but it was nearing the end. And they're back in the same kind of task. This is the same kind of paradigm, that is. This task is a little different. It's wooden pegs that are different colors and wooden balls that are different colors. And the task is to match up the ball with the correct wooden peg. So little kids can figure out very easily that you put the ball on the peg and that works, and they could care less about matching the colors. So it's a challenging task for parents who are supposed to get the child to match the colors with the pegs. So here we go. Okay, again, in the interest of time, I'll stop it, but basically you get the idea. All of a sudden, this game is gone, this teasing, taunting. They can be with one another, they can enjoy being together, and most importantly, he can focus on the task. Imagine, if you talk about school readiness, if you go to school and you're filled with frustrated, angry feelings and feel unsupported, how are you going to learn anything? It's only if you feel relaxed and supported and secure that you're able to actually take on these challenges that school presents. Okay, so I know that 2 years ago at this meeting you had Vince Felitti come and talk about the Adverse Childhood Experiences study, but since I'm supposed to talk about health, I can't resist talking about it because it's such a critically important study that has really been incredibly illuminating and important. So just to review for you, there are 13,000 subscribers to Kaiser Permanente at the HMO in San Diego. They range in age from their mid-20s to their mid-60s. They're given this 10-item questionnaire, just yes or no, in childhood, did these things ever happen? And the first stunning thing is that there's a lot of adverse childhood experiences in this very middle-class population in San Diego, as demonstrated in this slide. But what's important about the study is that they showed a linear relationship between the number of those adverse experiences and risk for subsequent outcome. Perhaps it's not so surprising that depression is one of the things that was found, but other things are amazing. A 7.4-fold increase for alcoholism, for drug abuse, depression, suicide attempts, but also ischemic heart disease, cancer, a whole variety of health outcomes that the number of adverse experiences that children have increases their risk for these adverse experiences. For individuals who reported 7 or more adverse childhood experiences, even if they didn't smoke and drink and were not overweight, had a 360% higher risk of heart disease than those with 0 ACEs. Think about that. 360%, even in the absence of these other risk factors. In other words, the experiences that we have are not only responsible for our pathways to school readiness, they're also incredibly related to our risk for health problems. So here's back to our study of self-regulation, looking at kids at age 5, following up at age 32. And what we find is that the increased risk for physical health and for substance abuse dependent are incredibly related to which quintile of self-control. So low self-control, much higher risk for poor physical health or substance dependence at age 32. I think one of the most exciting areas in this whole field is work in epigenetics, where we're looking at the effects of experience on a variety of gene expression things. Telomeres, you may have heard of, are these little ends of the chromosome. It's sort of like the plastic at the ends of your shoelaces that keeps your shoelace from unraveling. The telomeres are what keeps the chromosome from unraveling. And it turns out that telomere length is an index of cellular health and therefore of health in general. So the longer the telomeres, the more likely the cell is healthy. And there are now an increasing numbers of studies that have looked at telomere length in relation to a variety of adverse circumstances. This is a study of neighborhoods, not even families, but neighborhoods. And neighborhoods that have higher levels of perceived disorder and chaos have children who have shorter telomere lengths. They're also looked in the same study at the impact of witnessing violence, and children who witness violence, particularly girls, are more affected or have shorter telomeres than girls who did not witness violence. So in other words, we're looking now at the effects of environmental conditions and experiences that children have on cellular and molecular processes, which are obviously going to be incredibly important for health. And I think the next 25 years, this is going to be the major area of growth and research. So, children like Devin, who have this degree of aggression. This is a study of 1,300 kids from 10 sites around the country. And this is a cluster analysis. So each of these lines represents a cluster of kids, a group of kids. And these 2 through 9 down here are ages 2 years through 9 years. So what this shows is kids who have this is increasing levels of aggression. Kids who have the highest levels of aggression at age 2 continue to have highest levels of aggression at age 9. In other words, this isn't a transient little preschool thing. This is something that indicates a child at serious risk for continued highly aggressive behavior. And if you look at what are the risk factors for being in this high group, it's less involved and less sensitive parenting. And the consequences of aggressive behavior like this are considerable. This is just one example. This is Walter Gilliam's study that demonstrates that pre-K students are expelled at a rate 3 times higher than kindergarten through 12th year students. And if you're in private pre-K as opposed to public or state-funded pre-K, the risk is even more dramatic and even higher. So you're beginning your scholastic career with expulsions. So not only do you have all the risk factors that led you to that in the first place, now you have the additional experiences of being kicked out of this school or that school or that school, which of course increases your risk for more problematic adaptation later on. Now, many people are uncomfortable with the idea of psychopathology in young kids, and particularly psychiatric diagnoses, but it turns out if you do what Helen Egger did and you assess kids in pediatric community clinics, this was in Durham, North Carolina, just kids coming in for pediatric visits who were between 2.5 and 5 years of age, and you administer a structured psychiatric interview to their parents, what you find is that the rates of disorder in preschool children are not very different from the rates of disorder in school-age children and adolescents or even adults. You have very high levels of psychiatric disorders identifiable in kids between 2.5 and age 5. And in addition to that, she showed that just as in the ACE study, that the cumulative number of what she called major stressful life events is linearly related to increased risk for psychiatric diagnoses. Okay, so I'm back to Romania just briefly because I want to show you a couple of things from this study that I think are important. So we did our intervention foster care versus care as usual, and we showed that placing kids at an average of 22 months of age in foster care reduces the likelihood that they will have an anxiety disorder or depressive disorder at 54 months of age. And we looked at, does attachment security at 42 months? So here we're at 22 months, here we're at 54 months. Does secure attachment to their foster care parent at 42 months of age mediate that effect? And the answer is yes. So in other words, once you put attachment security into the equation, this relationship no longer exists. What this translates into is the reason that kids have reductions in psychopathology at 54 months is because they form secure attachments at 42 months. So to the degree that you form a secure attachment at 42 months, it reduces your risk of anxiety and depression. This is not an assessment of this is the same study, not an assessment of the mechanism of the intervention. This is looking at caregiving quality that the children receive at 30 months of age. And at 30 months of age, we had kids in institutions, kids in foster care, kids who'd been returned to their biological parents, and kids who'd been adopted. So there's a whole mishmash here at 30 months of age. And the first thing we showed was that the quality of caregiving they received at age 2.5 years predicted total psychiatric symptomatology and psychiatric impairment at 4.5 years, so 2 years later. The quality of caregiving they were receiving at 30 months. And again, we asked the question, well, does security of attachment mediate that effect? And the answer is yes. In other words, wherever you are, whatever setting you're in, whoever your caregiver is, to the degree that you form a secure attachment to that individual, it reduces the probability that you will have psychiatric impairment or psychiatric symptomatology at age 54 months. Okay. So, in infant mental health, what are we trying to do? Reduce or eliminate suffering. So we can't forget about the here and now. It is important for us to sell our services on the basis of future returns, but the here and now matters also. We have kids who are living in really problematic conditions, experiencing significant distress, and so we need to keep that in mind. And then for the outcomes that we'd like to prevent, you round up the usual suspects, and these are the kind of things. And of course, we're trying to enhance social competence and promote resilience. So essentially what we're trying to do with a child like Devin is move him from an adverse trajectory where he's headed for very serious and problematic outcomes and move him to a more adaptive trajectory where he's going to be not experience those kind of things. And you can organize, it turns out, infant mental health services. This is kind of a public health perspective, if you will, where you have universal interventions, and a good example of that is this quality rating system, where you're trying to get all kids into quality childcare, selected interventions, and the classic example of that is David Oll's nurse-family partnership. There are other home visiting models that also have been shown to be effective, where you select a group at risk defined in a certain way, you provide the intervention, and there's amazing data about the preventive effects of that intervention. Indicated interventions, where you take children who've already experienced adversity, and this would be kids who've been maltreated, and what you can show is that with enhanced interventions, you can make a very dramatic difference in outcome. Mary Dozier's work has shown this in several randomized controlled trials. Phil Fisher's work in Oregon with kids in foster care has shown that maltreated kids who receive this intervention can be protected from adverse subsequent outcomes. And then we have treatment in infant mental health, and we have an increasing array, an increasing body of evidence demonstrating the efficacy of a whole variety of different kinds of intervention for young children that have made, in randomized controlled trials, have made significant differences in outcome, and that number seems to be growing over time. This is the well-known model of James Heckman, which just shows, if you're interested in understanding this from an economic perspective, that the highest return on investment comes from the earliest possible intervention. It's not that these things are unimportant, schooling and job training and all things, but the return on investment for those kinds of societal interventions are going to be far less than the return on investment in early childhood. There's a kind of continuum of frameworks in infant mental health. You have the researchers who are cautious and skeptical, and rightly so, and want lots more evidence, and every study is a call for more studies and that sort of thing. The problem is, if you wait for researchers to agree that something is actually true, you'll wait several lifetimes, right? On the other hand, you have clinicians who are out in the trenches, and they've got to try whatever they can try and do whatever they can do and try to make a difference, and they've got to believe that what they're doing makes a difference, even if there's not a lot of evidence to support that. And so they're very pragmatic, they're very optimistic, hopefully. And then you've got your policy people in the middle who have to sort of balance. They can't invest in every willy-nilly intervention that comes along that some clinicians are excited about. On the other hand, they can't wait for overwhelming consensus that this is really effective. They've got to figure out how to target investments and make them in an intelligent way. Okay. So in conclusion, infant mental health emphasizes the importance of caregiving relationships, and that's because relationships are what promotes social competence. Social competence is what promotes success in school, in health, and in mental health. We have an increasing array of services that are available and known to be effective with young children and their families. And ideally, when we're developing systems, we'll develop them within this model of universal, selected, indicated, and finally treatment. So I want to thank you very much for your time and attention, and it's been wonderful to be with you.
Thank you very much, Dr. Zeanah. He has a wonderful ability to take a lot of research, a big literature, and just really refine it and bring home the key points in a very accessible way. So I apologize that we are running long and we don't have time for Q&A, but I encourage you, if you do have a question, to come up and ask Dr. Zeanah as we conclude now. So many of our service providers are staying for an afternoon session with Dr. Zeanah, and that's going to be next door. Before we end, I would like to say one final set of thank yous, and that's to the staff of Invest in Children. In the past, I've done this at the beginning of the meeting, and they're always out in the hallway, and they always miss it. So I hope that everyone's inside and able to hear. So many thanks for their work every day, but particularly today, too. Bob Stabe, Anja Abdullah, Nakia Robinson, Helen McCoy, Marcus Cortez, our newest member, John Ladd, and Mary Delaney. And a real special thanks to John and Mary who helped to really put this event together. So one reminder again to respond to the parenting survey. Also, if we can have that final slide, please like us on Facebook. And as of today, we are going live with a Twitter account at Cuyahoga Kids. So I have to admit, I've been dragged kicking and screaming to this, but we are going to start tweeting. So please follow us. Apparently the number of followers you have on Twitter is some measure of status. So the more the better. So thanks again for being here, and we look forward to seeing you again next year. Bye-bye.